Hi, hi. Well, it's almost 7 o'clock, but I think we can wait for three or more minutes. So we will start in 3 minutes. Well, we are going to start. Well, ladies and gentlemen, good evening and good afternoon to each of you, wherever you may be. As we embark on a new beginning with the arrival of the new year, I hope joy and peace accompany each and every one of you. I'm pleased to announce that the first Journal Club of the year 2024 takes place in South Korea. I will introduce today's speaker, Jae Jo. He graduated from Seoul National University College of Medicine and completed his pediatric residency at Seoul National University Children's Hospital. Following the completion of his residency, Dr. Jo continued his professional journey as a clinical fellow in the Department of Pediatric Neurology at Seoul National University Children's Hospital. Today, Dr. Jo will present on a recent publication in epilepsy from his team regarding the outcome of second anti-seizure medication withdrawal in pediatric onset epilepsy patients. If you have any questions during the presentation, please type them in the chat box and Dr. Jo will address them following his presentation. Dr. Jo, you can share your slide.
Okay, let me just share my slide. Can everyone see my slide?
Yes, it's
Okay.
great.
So thank you for the nice introduction and Happy New Year's to everyone. And I'm extremely honored to be the first presenter of Asia Oceania Journal Club Series of 2024. And as Dr. Choi introduced, today I will be talking about a publication that came from our team that deals with a second anti-seizure medication withdrawal in recurrent pediatric onset epilepsy patients. So withdrawing anti-seizure medications, why is this important? So as the pediatricians, we always want to, as we want to start our medication, the one question that every parent asks when we're trying to start the anti-seizure medication is, when can we quit? And that's even before the first dose. Why do we really need it? Why do we really need to quit the anti-seizure medication? There has been a numerous studies that deals with why we should withdraw anti-seizure medications in seizure-free patients is because they report an improved quality of life in seizure-free patients without anti-seizure medications. And of course, the less adverse events that is associated with anti-seizure medication is always a problem in patients with epilepsy patients who are in a seizure-free state. So there has been a lot of studies that deals with anti-seizure medication withdrawal, and the landmark study that has been published in 2017 in Lancet Neurology performed a meta-analysis of 45 withdrawal studies that encompasses 7,000 patients, and they enrolled around 2,000 patients to be reviewed in the study. The mean follow-up period was 5.3 years. was quite interesting to see that many publications have different number of success rates, but the meta-analysis showed 46% of seizure recurrence in the initial anti-seizure medication withdrawal. In the multivariate analysis, they looked into the factors that affects the outcome of seizure medication withdrawal. In conclusion, so longer epilepsy duration before remission, shorter seizure freedom free interval, younger age of onset, presence of febrile seizure history, absence of self-limiting epilepsy syndromes, higher number of seizures before remission, and presence of developmental delay, and of course, the abnormality of EEG before withdrawal results in higher risk in seizure recurrence after the initial withdrawal of anti-seizure medications. They actually did a nice job of presenting a score sheet where we as a physician can use in our daily lives, where it tells you the chances of seizure recurrence after anti-seizure medication withdrawal. You can do the point calculations that is provided in the study. And of course, these chances of seizure freedom at 10 years follow-up is also provided. They also do a nice job where manual calculation is quite difficult. They actually provide an internet web-based tool. It's epilepsypredictions.info. And you can go into this site and you can click your patient's information one by one based on the seizure durations, number of AEDs, age of onset, and they give you a nice calculation of chances for seizure recurrence at 2 years, 5 years, and 10 years. So after the study, not a lot of anti-seizure medication withdrawal studies has been published because this was such a big study that encompasses a large number of patients, and people no longer thought it would be interesting to publish these studies. But our question lies in the patients who failed in the initial anti-seizure medication withdrawal and reached a second seizure freedom, and what happens to them. So this concept is usually more common in the pediatrics neurology department rather than the adult department, because as their age of onset is much younger than the adult epilepsy, a lot of patients want to withdraw themselves from anti-seizure medications. So there has not been a lot of studies that deals with these kind of concept. This is actually the only study that deals with second anti-seizure medication withdrawal in a recurrent epilepsy patients. And this study actually talks about what we should do as a physician and what we think as a physician in terms of second anti-seizure medication withdrawal. So they did not really review the charts. They did not look into what factors that really affected the results. They actually did an interview of 94 pediatric epileptologists in the United States and Canada. What was quite interesting is that they actually separated the two groups into a more experienced and less experienced group, where the less experienced group had an experience as a neurologist for 5 years, and more experienced group had an experience of 22 years. And I guess most of the participants here are in the less experienced group because this is the Young Epilepsy Society Journal Club. It was quite interesting to see that a lot of physicians thought that the second attempt of anti-seizure medication withdrawal, a longer waiting time of seizure freedom was needed. It was also interesting because a less experienced physicians tended to have a shorter seizure freedom rate, which I guess makes them a little bit brave than the more experienced group. So, and the factors that physicians felt were a compelling factor for a successful anti-seizure medication were these. It was quite interesting to see that patients' request, or patients, I guess, or the guardians' request was a big favorable factor for seizure medication withdrawal. And of course, normal EEG, normal MRI, and presence of self-limiting epilepsy syndromes were favorable factors that was noted by the physicians in the United States and Canada. What about the unfavorable factors? So this is quite obvious, actually. So something specific, something as structural etiologies, something specific, patients with specific etiologies, and patients with younger onset of symptoms were unfavorable factors that was responded by the physicians. So our study was concentrated on looking at the patients who failed the initial anti-seizure medication withdrawal and reached second seizure freedom and underwent another anti-seizure medication withdrawal, which we call it the second anti-seizure medication withdrawal. And we looked into the charts of these patients retrospectively to look at the results of second anti-seizure medication withdrawal and the factors that affects the prognosis. So we recruited 8 patients who were diagnosed before the age of 18. We looked into the patients. We looked into our medical records for 20 years, and we defined seizure-free state as a 1-year seizure freedom after anti-seizure medication withdrawal. We excluded patients who performed brain surgery or epilepsy surgery during the course of their disease, and patients who underwent short-term anti-seizure medication therapy less than 1 year were excluded from the study. And now I'll talk about the results of the study. So in total, we recruited 104 patients, and 12 of the patients, which is 11.5% of the patient, had an abnormal MRI reading at diagnosis. Only 10 of the patients, 9.3%, showed developmental delay or intellectual disability. And 14.4% of the patients had a specific etiology, either that underlies in structural, infection, immune, or genetic etiologies. Most of the patients did not have a specific etiology to start with. The mean age of diagnosis was 7 years, and only four patients had family history of epilepsy, and 7 patients had history of febrile seizure during the course of their development. And we tried our best to classify the patients into the epilepsy syndromes that was published by ILAE in 2022. 16 of the patients were categorized to have self-limiting epilepsy syndromes. 8 of the patients were categorized to have other epilepsy syndromes, and most of the patients, which is 76.9%, fell into unclassified epilepsy syndrome. And these were the clinical states at first and second withdrawal. As you can see here, at the first withdrawal, the age at withdrawal was 12.2 years. Abnormal EEG at withdrawal was observed in 19 patients. Epilepsy duration was 20 months, and seizure-free durations were 33.6 months. Before the second withdrawal, most of the patients were in their university age, which is 18.1 years of age. Around 18.3% of the patient had abnormal EEG at withdrawal. Epilepsy duration was much shorter during the second withdrawal, where epilepsy duration means the duration of seizure onset to the last seizure before they reach the seizure freedom. And seizure freedom was also very long, which is about 3.5 years to 4 years compared to the first withdrawal. Most of the patients were receiving 1 anti-seizure medication to control their seizure, where the average number of anti-seizure medication was 1.2. So now the outcomes, and now I'll talk about the outcome and the factors affecting the prognosis of second anti-seizure medication withdrawal. So of the 104 patients who underwent second anti-seizure medication withdrawal, we observed seizure freedom in 41.3% of the patients. And we also looked at the factors that were affecting the results of the outcome. And quite surprisingly, abnormality in MRI or developmental delay or intellectual disability, which were a significant factors in the first factors affecting the success rate of first anti-seizure medication withdrawal, were not significantly important in second anti-seizure medication withdrawal. However, patients with a specific etiology, either structural, infection, immune, genetic, resulted in a worse prognosis. And of course, patients who were classified to have self-limiting epilepsy syndromes were very likely to be successful in reaching seizure freedom even after recurrence and underwent second anti-seizure medication withdrawal. We also looked into epilepsy durations before second withdrawal, seizure-free interval before second withdrawal, number of anti-seizure medications, EEG abnormality, and ASM withdrawal durations. These factors, where epilepsy duration and seizure-free interval was also very, very significant factors that affect the success rate of second anti-seizure medication withdrawal. As you can see here, the epilepsy duration is much, much shorter in patients who shows seizure freedom after second medication withdrawal. It was also quite interesting to see that EEG abnormality before second withdrawal and ASM withdrawal duration did not significantly affect seizure withdrawal outcome during the second withdrawal of anti-seizure medication. We also looked into the clinical factors during the initial withdrawal, where patients who relapsed during the course of tapering the anti-seizure medication during the initial withdrawal were likely to be recurred during the second seizure anti-seizure medication withdrawal, where almost half the patients who relapsed during the first anti-seizure medication relapsed after second seizure medication withdrawal, whereas only 20% of the patients recurred after the second medication withdrawal. I guess this also means that higher seizure burden is a likely factor that affects the outcome of second seizure medication withdrawal. And we also performed a multivariate analysis to see which factors most significantly affected the results of second anti-seizure medication withdrawal. Of course, self-limiting epilepsy syndrome was the most significant factor, which is quite obvious, but also the seizure-free duration before the second withdrawal and relapse during tapering at initial withdrawal were the factors that significantly affected the outcome of the second medication withdrawal. So, and lastly, we also wanted to address this question, which we think is a very important question that must be addressed as we want to taper anti-seizure medication in pediatric patients. The question that we get asked the most is, what if seizure gets worse if it recurs after the second withdrawal? Which means that the patient may not want to go through this process if something gets worse, if they take the chance of second withdrawal. So we looked into our patients, and of these 61 recurred patients, 13 patients required addition of another anti-seizure medication or increment of previous anti-seizure medication. Around 80% of the patients remained seizure-free after an immediate reinstatement of previous anti-seizure medication. And also, all patients remained seizure-free for at least 1 year of follow-up period, meaning that even in the 13 patients who required a small increment of previous anti-seizure medication or required addition of another anti-seizure medication, or remained seizure-free for at least 1 year. To summarize my talk, the success rate of second anti-seizure medication withdrawal in pediatric onset epilepsy patients was 41.3%. Etiology, self-limiting epilepsy syndromes, epilepsy duration, seizure-free duration, relapse during initial tapering were significant factors affecting the success of second anti-seizure medication withdrawal. Of course, this is a retrospective study, so it does not give you the full picture of second medication withdrawal. So maybe a future prospective study could be done to fully understand the phenomenon, but this is something that would not be allowed by the IRB, especially in the pediatric patients. And as suggested by my talk, a tailored second withdrawal in recurrent pediatric epilepsy patients may be beneficial because even after failure, something serious does not happen. So I would like to end my talk with an AI-generated image. I actually inputted a prompt saying a kid is happy about not taking medications anymore for a second time. And this image popped up. As you can see, this is an AI-generated image. The feed is a little bit wrong, but this was done in 2 seconds. We now live in a world where medicine is changing so quickly, and we believe that precision is the key, and a tailored medicine and tailored approach in anti-seizure medication withdrawal could be very important. Thank you very much, and I'll accept any questions if there are any.
Thank you, Dr. Zhou. Thank you. Thank you so much. Well, the last picture is very interesting. And there are some questions from the chat box. Was the anti-seizure medication used before the second withdrawal same as the one before the first withdrawal or different one? I guess almost all cases have had the same one. If so, what is the difference mechanism or trigger of the seizure recurrence between after first withdrawal and second withdrawal?
So first, to answer the first question, so these 19 patients are not the same. They just happen to have the same number, so they're different patients, which we thought was quite interesting. This, I guess, reflects the basic tendency of our institution, where we accept around 20% of abnormal EEG and withdrawal, abnormal EEG, if we try to attempt anti-seizure medication withdrawal. And different mechanisms or trigger of seizure recurrence. So we did not look into factors that trigger the seizure recurrence, such as fever, infections, and etc. But we believe that higher seizure burden usually tends to result in anti-seizure medication recurrence in second withdrawal. Did I answer your question?
So did you compare the medication, the
drugs,
substance of the drug?
Yes, we did, but there were no significant factors that really mattered. Whether the patient uses valproate, whether patient uses Keppra, it didn't really matter in terms of the outcome of second withdrawal.
Thank you. And
so the second question, great study, superbly presented. Thank you very much. Interesting that EEG abnormality was not associated with recurrence. Did EEG abnormality in the study indicate a spike wave discharges alone? Okay, that's a good question too. So
Yeah.
that's exactly what the reviewers asked during the review process. EEG abnormality refers to only spike and wave discharges, not background discharge, not background slowing or abnormal backgrounds. So only spike wave discharges. I should have corrected this to epileptiform discharges in EEG.
Yeah, right.
Which was corrected in my manuscript.
And
Third
another
question:
question.
If patients have seizures for free last 6 months, if patients have seizures free, can ASM withdrawal? Can you still be abnormal? Yes, that is true. The patient may still have an not abnormal EEG, epileptiform discharges from their routine EEG for around 20 or to 30 minutes, but still remain seizure free. And many studies indicate stated that EEG spike wave discharge, epileptiform discharges in EEG did not really affect the first anti-seizure medication withdrawal. However, in the meta-analysis, they showed a slight significance. That's so another question, that is, what was the nature of please stop me if you have any questions, or if I did not answer your questions correctly. So another question would be, what was the nature of MRI abnormalities? I would think there must not have been focal cortical tips. So we also looked into these. So 2 focal cortical dysplasias, 6 cerebral atrophies, and some other lesions, but not a lot of patients really didn't have MRI abnormalities at the diagnosis, because also, I mean, our institution, physicians at our institutions were not brave enough to go through 2 anti-seizure medication withdrawal in many patients with anti-seizure MRI abnormalities. Is your study suggesting that we need to wait longer before trying for second withdrawal to increase success rate? Is there a different period that we should wait for a specific syndrome, like self-limited epilepsy syndrome, that you can suggest? Probably shorter. That's also a very good question, and that's a question that must be addressed in a different setting, a different form of study. For the second question, we believe that's an important topic that we must address in terms of pediatric neurologist, because these are patients that we see a lot, and we believe, and I strongly believe, that there could be a different period of seizure freedom before the second anti-medication withdrawal, but this is something that must be studied. For the first question, so is it the eggs first or the chicken first? So one of the question is, did waiting for a longer period of time really affect the outcome, or is it just a correlation? I believe, but this is just where I'm just probing into what I know, I guess, is that I believe that waiting for a longer period of time usually results in a better outcome. However, as I said before, patients who tended to immediately reach seizure freedom after initial withdrawal tended to have better results in second medication withdrawal. That probably also is correlated with longer seizure-free interval. So I think it goes together. So, and reducing seizure burden itself would probably result in better outcomes. So I think waiting for a longer period of time would be a better choice. Another question, a lot of questions. Thank you very much. Did the study include developing a predictive model of scoring to predict seizure occurrence? Yes, that's also a very good question. So we did not. That is because we thought suggesting a score model with only 100 patients in total could be a little bit risky and misleading, I guess, to the scientific community, because we thought this was just not enough strong evidence for people to use to score their patients' chances of seizure recurrence. But we thought giving them a general concept and general idea of factors that affects the outcome will be good enough. Thank you for the
I
talk.
think we should like
Yes.
collect a large number of patients who has been tapered try the second anti-seizure medication withdrawal. Like we have to like collect a number, quite a large number of patients, right?
Yes, and as I said in the initial part of my talk, this is something that is usually generally accepted in the pediatric neurology section, but not in the adult neurology section. So there are not a lot of patients who goes through this process. So I guess since we are all together here, maybe we could all collaborate and collect patients together and maybe do a large-scale study to provide a scoring system to really benefit the patients in a precise way. Now, another question, could we improve the success rate of applying? Yes, that's also a very good question. So I think the key message from this study, this also goes to the question from Dr. Woo-Jung Kim, is that should we wait longer? Should we what could we do to improve the success rate? That's something that is really hard to say based on our results, but our results indicate that attempting second seizure medication withdrawal in patients with small seizure burdens is quite safe and does not result in worsening of the epilepsy. So I guess the key message from our study is not that we can do something to improve the success rate, is that we should choose the patient correctly and we can attempt the second withdrawal without fearing too much of having too much recurrence or worsening of the patient's disease itself.
Thank you. Thank you. Well, nice talk, and we think we discussed a lot. And if you have any more questions, well, I have the last question, like regarding why did you focus on the outcome of second withdrawal rather than the initial withdrawal of anti-seizure medication? Since the study specifically addresses patients who had previously stopped anti-seizure medication, the findings are like confined to individual with self-limited or benign courses of epilepsy or structurally normal epilepsy patients. So why did you choose like second withdrawal?
So to be honest, as I introduced you guys, a landmark study has been published in 2017, and no longer people are interested in first anti-seizure medication withdrawal because this study actually concludes it all, I think. But I guess the topic has to do, the reason we chose this topic is first to make it published in a better journal. And of course, secondly, we thought that we reviewed all the studies and nobody really talked about this topic. But it is a very widely practiced practice in pediatric neurology. So this is something that we really wanted to address. We also want to look into the outcomes of a specific epilepsy syndromes, especially the self-limiting epilepsy syndromes. And that's something that we want to pursue in the future.
Thank you. Well, if there's no more question, I think we can end up this session. So thank you, Dr. Joe, Thank you for your insightful presentation. And thank you for everyone who joined us today. Have a pleasant evening, and we will see you next journal club, right? Take care.
Thank you very much.